Good afternoon, ladies and gentlemen. I'll start live case session 3. I am Hyun-Sik Park from Gyeongbuk National University Hospital. Dr. Lee?
Yes.
Can you hear me?
Yes, I can hear you.
Yeah.
Nice to meet you. Let me introduce my colleague, Dr. Chang-Hwan Lee, from Bone Hospital. 맞죠?
Yeah. Thank you.
Let me introduce today's case.
49 years old man was admitted for the evaluation of exertional dyspnea for 6 months. He underwent already PCI at the OM 3 months ago. Salient facts showed partial reversible medium-sized perfusion defect in RCA territory. Coronary angiogram showed total occlusion of proximal RCA with breaching collateral. His medical history was non-significant except hyperlipidemia and ex-smoker and familial history. His echocardiography showed normal ejection fraction without regional wall motion abnormality.
Okay. Can you see today's angiogram? Yes, this is a bilateral simultaneous angiogram. As you can see, the region is very, very simple. Next. This is a LAU, caudal view, spider view. In proximal RCA, spider view elongate the region, so sometimes very helpful. Next. This is a RAO view. It looks like there is some microchannel. Next. This is RAO view. If the anterior approach fail, I'll check the collateral connection. There is some collateral connection between LAD and PDA. First of all, this case, I think, must be done antegrade postally. The guiding catheter is next. AL, 7-branch AL1, side wall. The guiding catheter is relatively deep engaged. However, the vital sign is stable. And the guiding catheter was introduced just near the proximal occlusion body. So, I don't use micro catheter, only wire. At this time, I want to panel to which guide wire you will choose.
Okay. So you asked which wire?
Yeah. Yes.
Okay. So there's some moderator, some comment.
Dr. Lee, this is not CTO, real CTO, right?
No, no, CTO is right. As you can see,
This is a CTO live demo.
CTO-like lesion, but not real CTO. In different projection, I could see the channel. Even visible channel, the functional channel, we can try with the XTR.
okay.
Or even I feel the Xeon black or such kind of software can even negotiate quickly. It's too simple for you.
And another opinion.
Any other question? Any other comment from the moderators?
In our country, in Egypt, you don't use Gaia at the first because it's expensive. So we start by just a BMW and then PT2 or a Pilot 50, and then we go to Gaia the second, or sometimes further XT. So the escalation comes just by the cheaper, and then which can be easier. If it is high scoring of the high breach collaterals, very calcified, so I think from the beginning we cannot go for the steps BMW, go for Gaia for at the beginning with the microcatheter.
Microcatheter. Okay.
Wasan?
Yes.
Originally,
Yes,
micro.
hello. Yes.
Yes.
I think in Thailand we also consider about the cost and the economics. So we usually in this case maybe we can do just only simple antigrade without micro catheters and with only the one guide wire. Maybe just XT or Chiong may pass the lesion.
Sure. Okay. I agree with your opinion. The patient is not poor, but however, the guiding catheter support is very, very strong. So I use only single wire. As Dr. Ra Seung-Woon said, I use polymer coating wire, Sion black. Next. 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 This is a real image.
This is the magic wire.
Yes. Yeah. And after free dilatation with 2.0 millimeter balloon, we check the IVUS. Please show IVUS.
Sure. So this is starting just beyond the RV branch. The RV branch is here. You can see it's a large plaque burden. This is a huge vessel, easily 4.5 millimeters. RV branch, now we're proximal to the RV branch. Again, 1, 2, 3, 4.5 or more millimeters. Some deep calcium, which is not important. Remember, this is post-balloon up. So here the plaque is much more concentric. But the only real surprise is that the vessel is very, very large. The plaque burden is very, very, is a lot. If you remember some of the cases from the last live transmission session, some of the lesions were very negatively remodeled. This is not. This has a large plaque burden. And then we get proximal. You can see the vessel opens up again, and we have a good 4.5 millimeters or so.
Yes.
Gary, one of the questions regarding the CTO, how often you see attenuating plaque in the CTO segments? How often you can see?
You see it commonly, but it's not a rule. Okay. Probably about a third of the time. For example, here there's no attenuated plaque, even though there's a large plaque burden. You see mostly, deep calcification.
Because following the question is how often you recommend it, because attenuating plaque is a higher instance of maybe 10-15% slow flow, so we are maybe considering of protection, distal protection of filter.
Well, it's there's a practical aspect to being able to protect the distal vessel in the CTO. But most of the time, it's really not an issue.
Okay, according to the IVUS finding, we put the stent is next.
One of the things, I'm sorry, the length is about 26 millimeters.
Next. We put the Oshiro stent. The length is 30 millimeter and the diameter is 6.5. And next. Next. And after I was finding, stent is well opposition, but some under expansion. So we post high pressure balloon with 40 millimeter balloon. Next. Next. This is last view. Because other cast room case is very complex, I finished already. Please focus on other cases. Yeah. This is final view. Yeah.
Okay. Thank you for your nice job. Thank you. Congratulations.
예, 예, 아시오 탈락하죠.
Dr. Dimitri, you are on the air.
Hi, how are you?
Yeah, how are you?
We're doing well. So we can show you the pictures. Dr. Kim
Okay.
can go through the history,
Yeah.
and then we'll tell you what we've done so far.
Okay, so let me present our case. Is a 57-year-old male was admitted for chest pain for several months. The SPECT scans showed a partial reversible large size
Have,
perfusion
an
defect
XT.
in LAD
XTR.
territory. On his echocardiograms, A kinase of elbow apex with a normal systolic function. And his coronary angiogram showed proximal LA CTOs. On past medical histories, there was no specific history. Next. Here is a smoker, and then his clinical presentation was a stable angina. Next. Yes, on the echocardiograms, there was a reasonable motion abnormalities. The A kinase elbow apex, the elbow systolic function was normal. Treadmill test was positive. On the thallium spec, the partial reversible large size perfusion defect was noted on the LAD territory. Next. Yeah, so our reason was LAD. Yeah. Next. Yeah, it's done.
And then we're ready for the angiograms.
Angiogram.
We can show them from today. So we can show you the angiograms from today. Can you see the angiograms?
Yeah, I can see that.
So this is an RAO cranny shot. There's not too much contrast going there, so we just repeated it. And actually there are some septals that appear relatively promising. Particularly there's a second kind of a branch of a PDA at the bend, where it seems that after a little bit of tortuosity it may be connecting up to the LAD. And here is the spider view, which you could make an argument that there may be a little of trickle of contrast down this very calcified LAD. So we know from the CT scan and the prior angiogram that the length is about 37 millimeters. So my thought was initially, given on the fact that the collaterals, and also the distal cap is at the bifurcation with a diag. If you can see it there at the very end, there is a diagonal, which is not of insignificant size. So our thought was to explore briefly at least, if we can get into the most promising collateral, which is the one at the distal part of that small parallel, so to speak, PDA, and then take it from there. And that's where we are. And believe it or not, it has been not very easy to engage this. There's a lot of motion at that area of the heart, and there is at a bend, so it makes it difficult to engage it. So I've tried Xion Blue, couldn't do it. Unfortunately, we don't have Whisper or Pilot. And now I'm going to just try an XDR and see whether I can just get in there. Once I get, if I get and I advance the Corsair, then I will take a Xion and see whether I can negotiate that collateral. Little test, please.
So you didn't do the antigrade preparation?
No, I wanted to see what my options are for retrograde. And again, I'm not going to spend the entire session here. If I can't get like within 10 seconds here, I'm going to go antigrade. Little test, please.
So he did not try the antigrade attempt
No,
from the
little test.
beginning, yeah?
No.
Primary ritual.
Correct.
So what are the main reasons? You feel some fear of the risk in the main bifurcation area to injure the area osteal distal left main?
That's also part of the consideration. So if I could get retrograde quickly, I could potentially minimize the time that I would spend in the...
Because when we consider the RC tortuosity and relatively slender channel from the right coronary, most of the operator will try to enter the option because there we can see some clearly visible calcification marking along the entire CTO segment and some suspicious stump area in the D1 bifurcation. How about Dr. Wu?
I don't disagree with none of these comments. The reason I wanted to briefly start retrograde first was for the left main and also because the distal cap is at the bifurcation. So it would, if I can get retrograde, maybe have better chance of preserving the diag. But again, this is not working very quickly, so I'm just going to go antegrade.
One of the questions, because it's not a very good collateral channel, because including that the PDA is very tortuous. One of the questions I might ask Muramatsu, because he's doing a lot of retrograde, this kind of bending, is there any tip and tricks, or maybe Japanese colleague they can answer, this kind of tip and tricks, how to negotiate? Sometimes we need a double lumen microcaster to negotiate, bring the septal selected, and you have the trapping again, then you might bring your microcaster core cell to get to the exactly the septal channel. Then, so this is a difficulty of, you can visible, but it's actually big bend between that PTA to the truly septal possible connecting collateral. So maybe antegrade would be good option too for me.
I'm going antegrade as we speak. What is this? This is
I think this is very difficult for the retrograde because as you suggested, right coronary is very tortuous.
XTR.
And if you use the microcatheter deep into the right coronary, however, the tortuous, they make weak, the worse to the guide wire manipulation. So first of all, it is considering about how to stretch to the right coronary vessel because, for example, the corsair is nice because a little bit stretch to the vessel and easily guide wire manipulation into the collateral channels.
So
and
Dimitri,
second one
how much
is,
time and radiation did you spend on that retrograde attempt?
1 gray. I don't have 7.5 frames, unfortunately. So that was 1 gray.
Anyhow, so in this case, I think antegrade is a little bit more promising.
Yeah, I'm going antegrade right now, and again, depending upon how that goes, all these are excellent suggestions. Another option, except for the Crusade catheter, would be to get, I don't know if it's available here, to get the Supercross, which is an angulated microcatheter, and it's helpful in situations where it's difficult to get into a side branch. Let me just store the. I'm sorry.
How about Muramatsu, the external caliber difference between the fine cross, the course, when you consider the caliber, because there's LED arcs and the proximal portion, there's at least moderate to severe disease.
Yes.
So we should prevent the flow limitation to the diagonal branch. So in that case, maybe I will choose the fine cross at this situation instead of corsair.
Or put the standard first.
But best way is to, anyway, we should minimize the distal flow disturbance. Fine cross must be the good option. How about the crusade, the distal, the reference? A little bit thicker than the fine cross.
Crusade a little bit thicker.
Yeah, crusade thicker and the crusade also.
Crusade is a little bit thicker than fine cross.
So instead of a crusade or the corsair, it's better to use.
So the other difficulty is that we don't have a Pilot 200 here. So any suggestion for wires? I would use a Pilot 200, but we don't have it.
Dr. Muramatsu, in this case, which microcatheter is better among the caravan?
I think I'm very cautious about the LD just proximal calcified region. Yes, I don't like this, the small narrowing of the radiosum. So maybe.
Well, we're going to watch it very closely. So far, the EKG is fine, and the pressure is okay. He's not complaining of any pain.
Profile an XTO.
Profile is smaller one is a fine cross.
Yeah,
fine cross, but.
Yeah, but I don't think I'm going to have the support with the fine cross.
So what is your...
And I don't want to put a guideliner in there just because of the reason we
what is your first wire choice?
What kind of wire you choice?
This is a Gaia too. Can we go areocranic, please?
Gaia.
From the beginning.
So,
how about other operator?
So I think now we're on the revolution after Gaia, I mean. So if you don't have Gaia, Fielder XT will be the first choice?
I'm not using Fielder XT anymore for undergrade escalation.
In our country, maybe we will start from the XTA. And then considering escalation to Gaia first or second. How about in Taiwan?
Of course, I like to, if they have a possible microchannel, I like to be, stepwise. So, but maybe Dimitri, you like to just jump directly using the same taper wire, but somewhat penetration force somewhat stronger.
Dr. Nakamura? Yeah. Which wire do you recommend? For this yes, anti-grade.
So the depend of the plug hardness. So like this is the guide.
This is the Gaia, yeah.
Gaia first?
You're in second.
Second, yeah. I think if we can bring goes much more distally, Gaia second is okay, because now we can see the tip is moving, so the control is almost fine. So if we cannot control the tip direction, we may increase the thicker shaft wire.
Can we do a dual injection, please?
I think it's touching.
Yes, but that could be the longest 2 millimeters of my life here.
Sometimes you feel it more than you see it.
Dr. Byeong-Keuk Kim?
Yeah.
What size of guiding catheter? It's a 7 French?
7 French?
EBU?
Yeah, 7 French.
EBU.
The tip appears to be a little bit collapsed. So.
Yes.
Okay.
Wire go down.
Can we do a cine, please?
Basically, this kind of proximal moderate to severe disease, intermittent, basically we can follow by the contralateral injection. However, we should check the proximal patency, whether there's a thrombus formation is ongoing or there's no injury, flow limitation, something. Sometimes we need to check in the integrated flow.
Yes, we will.
Is your corsair stuck there, Dimitri, or is it?
No, I'm going to get a little bit further
advance it in, yeah.
Yes. This is where I would kill for a pilot, 200.
Yeah, you can make much support by Corsair.
Yeah, initially I wanted to leave it a little bit further back so that I could see the deflection of the wire, but now I need to penetrate through that calcium, so. Okay, so maybe that's a septal. Let's do a retrograde synapse.
Very good news.
Or it's muscle. I think it's septal. I think I'm going to see it in another view. Go LAO, please, and then I'm going to advance the Corsair and see if I can do something like an open sesame. LAO, yep. Retrograde cine, please. I think I'm going to have to advance the Corsair here, if that's okay with everybody. Excuse me. Did we check the ACT, gentlemen, again?
Okay. ACT, please.
There was no significant ectopy, so I think that I'm in a good spot.
It's fine. Pull back and try to redirect it.
Let me advance the Corsair a little bit. I'm trying to get the exact same angle here. Just give me a sec. Thank you.
Doctor,
Saline.
first wire is going to the septal branch.
Yes.
What next would you recommend?
I think
step.
Already is entered, so just redirection, simple redirection, we can try first.
How about the fairway?
Yeah, another
fairway
option is already the Corsair could enter into the tissue, CTO segment. So we can little bit pull back of the CTO from the CTO segment and retrieve into the guiding catheter. We can try another soft wire because already there's some bugination effect with the Corsair. We can do another parallel wire, soft wire to negotiate from this septal area to the far distal area. And there's another second option. Just a simple redirection, I think it will not be so greatly difficult in this situation. For sure, the operator doesn't want to lose the wire. It's another best option is to the parallel wire using another soft wire.
I want to create a little bit of a channel so that I don't give up what I have. And then all these other options I think are great options, but I want to try and get the Corsair slowly if it will go. It goes slowly. It's a very calcified lesion. We knew that was going to be an issue from the beginning. Maybe I can take like something a Shion or a Shion black with a bigger bend and see if I can negotiate the LAD.
You cannot push anymore.
The Corsair?
Yeah.
No, you see how it's getting kind of bent proximally. Okay, I'm going to try one more time to see if I can redirect. Otherwise, I'll take a different...
Can we make one wire in the septal and make a parallel wire in the main branch? As a parallel wire technique, because it's every time it goes to the septal, so I think it, as an anchor wire technique.
We could.
Sometimes wire directly connected to from the subintimal space to the
septal.
Yeah.
Can I have a Gaia 3, please?
So if there's a
Gaia 3.
chance of
Gaia 3.
injury, it's better
Yes,
to
yes, yes.
change another one.
Yes. Dr. Wasan? Dr. Wasan? How do you feel this situation? How do you overcome?
Yes. In this case, I think first maybe I use the XTR.
Second.
Even though there is some calcium, because XTR maybe you have tapering tip and maybe you can negotiate to go a different way, more than this and less aggressive, so don't lose the channels. And if not success, maybe Gaia second, Gaia third should be your choice.
Can I have a retrograde cine, please?
Any other comment from the moderator? Or any other idea?
Quite close.
Which wire are you using now? Same wire?
It's a Gaia 3.
Gaia third.
Gaia third.
I think I'm going to quickly revisit the retrograde again. Now I see from the previous picture we know that we have good, give me a little test please. Yes. Send it out please.
Maybe better to utilize some kind of rotation angiogram.
It's very hard.
I feel the tip bending appears to be too large, to gently lead.
Okay. Okay, let's make sure that I'm not outside his sternum. Let's do retrograde, please.
That's good.
Oh,
Look quite promising.
I see.
Nice.
Yeah, it's already in.
Yeah.
How did you do that?
I can't tell you. I'll have to kill you. So now, again, I don't know if I have the diag or not. We'll have to balloon and see. That's one of the problems with when we do a wire-based re-entry. It's very difficult to exactly say where we are. Now the question is, gentlemen, do I try to continue, get down with this Corsair, which I've already worked out a lot, or should I change another microcatheter or even balloon proximally? Give me a 1.5 balloon, please. And give me a trap, a 2.5 trap.
Patient has some chest discomfort.
Patient feel chest pain. Dr. Kim.
Yeah.
Yes.
Right dyspnea.
Yeah, why don't you check the anterior flow a little bit?
Sure. Not now, though, because I removed the Corsair. Let me get the Corsair back down to plug the hole.
Is this necessary to treat for the LAD still?
No, I think we can do quick pre-dilation then.
Yes. Let me just backplate it, Dr. Kim, for a sec. Give me a little antegrade test.
Antegrade test. Okay.
Just a little. No, I think he has flow to the diag. Again, maybe I was compromising some flow to the diag, so we're going to let him breathe here a little bit. I'm going to remove the Corsair. I'm going to dilate proximally. I'll take a 2.5 trap balloon, please. And what was the ACT?
Trapping balloon.
Usually when people cross, you tend to clap. I didn't hear anything.
2.5, okay. This is 2.5 trapping balloon. Nominal pressure.
Okay, go up, please.
8.
16, please.
16? Okay. Pressure, okay.
Pressure is still up. Because we have side holes. Let me see if this will move. If he's hurting, you can give him, would we have a little morphine or fentanyl or?
Not so severe.
Oh, okay.
Yeah.
That's fine. Just leave it up for now, please.
No?
No, leave it up for
Okay.
now.
1.5 balloon. This is 1.5.
What's the name of balloon?
Eupora from Medtronic balloon.
Okay, and then give me a new Sion blue just to throw down the circ, please.
Nominal pressure.
So, Dr. Dimitri, I will move to the next room, okay? And
Yes,
go back.
we're just going to do some dirty work here trying to crack that calcium. But we're going to, at this point, we're going to protect the circ because I want to balloon that ostial LAD as well.
Okay. Okay, see you later.
Yes.
Dr. Nasu,
Yes.
on your air.
Good afternoon, everyone. So could you explain the case?
This patient is a 71 years old man. He was admitted for airport chest pain. Coronary angiogram showed with RCA total occlusion with collateral from RV branch and left circumflex coronary artery. His coronary risk factor was hypertension, and he has atrial fibrillation on dual antiplatelet therapy. Next.
Dual antiplatelet therapy?
Next. Echocardiography showed a kinesia of basal inferior wall and with normal elbow ejection fraction. Thallium SPECT revealed reversible medium-sized moderate to decreased perfusion in inferior wall.
Okay, thank you. So, I can show today's shot. This is a simultaneous injection in the today's shot. You can see there is some tricky channel from middle of the RC to the distal. Actually, maybe distal RC itself maybe short segment CTO region is there. This is a cranial view. So there is some connection, but so anyway, the channel is very, very tricky. So like a corkscrew type of like a epicardial channel, right? So yes, this is a, and also I checked the septal connection, but this patient has a very good flutter of the RV branch, so I'm not sure that the connection between the septal to the PD branch, but this septal is very big, so if we need to the red approach, the chip injection from the red approach is one of the options, I guess. But anyway, the main carotid channel from the AC from the circumflex, but this channel is also epicardial. So maybe for the retrograde approach, maybe RV branch to the PD branch. I'm sorry that it's out of the screen, but the connection is not bad. So if we need to do the retrograde approach, so this channel is one of the options for the retrograde approach. So do you have any comment for this CTO region?
I think the same question like other cases. Do you start antegrade and fail, then you shift retrograde? Or you start retrograde to the beginning? What are the indications of initial retrograde approach rather than antegrade in your career lab?
Yeah, actually, my style is I always study from the antegrade approach. So because there is some, if there is very good carotid channel from the septal, promising way, so sometimes I started from the primary retro, but this is RC is also, this CDO has a very epicardial channel from the PD and the AC branch. So even though the channel inside the region is very tricky, but I would like to start it from the antegrade first anyway.
So you have 3 collateral channel. One of them is the RV branch, and
yes.
The second one is the AC channel.
Yes.
And third one is a small, tiny, maybe septal.
We are not sure exactly now, so that we should check to the chip injection. Yes.
Okay. Any other comment, Dr. Wu?
Yes, the choice of the collateral here.
Yeah, my concern is because the distal CTO kept antegrade is the big vessel, so it's kind of fenestrating CTO, but then to the distal cap that is somewhat ambiguous. So and the PTA to the distal RC, I think is quite is a good angle. So either way, you go from the AV channel or you go from the septal tip injection, I think is a good option. But of course, we can anyway you need the retrograde, you still need the antegrade preparation. So we can try with polymer check, taper tip, try antegrade, and we'll see. And if they stuck in the subintimal not too far, we can just start at retrograde. That's my consideration.
Dr. Nakamura?
Yes. So there's looks recognized channel, which is like kind of very complex. So it looks 2 channels connected, but we cannot understand certain point of the connection. So I think we can try to go antegrade. And antegrade line and retrograde line is a gap. So maybe the distal point is very difficult. So maybe start to antegrade, and if you have a chance to pick up the retrograde, is much better, I think.
Any other comment? Okay, more moderators start the antegrade. I agree with you.
Oh, okay. So I also studied with the antegrade approach. But this kind of the channel selection is very difficult sometimes. So next, please. So that there are the two channels around the bifurcation and the RV branch, small RV branch. So you can see the two lumen. The right side in the RF view is connected to the distal side.
Yeah.
So next page. So I use a color bell. It's because the color bell is inner lumen is bigger than the Corsair. So the chip injection, the image quality is better than the Corsair. So in this kind of situation, color bell is very useful. So this is cranial chip injection. Also in aerial view, we can see the double lumen around the bifurcation. Next please. So this is our review. It's the same. Okay, next please. Okay, I started from with XTR. The XTR can pass this double channel. Next please. Yes, like this. Okay, next please. Okay, next please. Yes, like this. So, but the XTR is stopped here. So I had some resistance, and also the chip of the XTR could not move. Okay, next please. So I advanced the caliber and the chip injection. So in a view, the channel looks straight, but next please. In our view, that there is some zigzag point just distal of the caliber. So I changed to the wire from the XTR to the SO03. So SO03 is very soft, and also in addition is very safer. And also sometimes we can track this kind of the very tricky morphology channel. Next please. Fortunately, next please. SO03, you can pass this bending portion. So next please. Okay, next please. Next please. So here is the chip injection from more distal side. So we can see there's some tricky, still tricky channel around the distal RCA. The next piece. So in our view, there is bending portion you can see maybe. So I try to negotiate this tricky channel using by the SO, but the SO can pass this bending portion. So also the XTR cannot pass. So I decided to penetrate this around there using the little bit harder wire. So I selected the Gaia first at this moment. Next please. So maybe you can see there's some discrepancy between the antegrade and the distal side. So next please. So next please. This is the SO03. SO03 cannot pass. Next please. Next please. Next please. The XTR is also does not work. Next please. Next. Maybe this is Gaia.
Okay.
Next please. Next. Next. Okay, so but the Gaia is go into the subintimal space like this. So, but we can see some flow from the antegrade in the channel. But maybe I mistaken the more proximal side. So I selected the upper side of the channel again. Next, please. Next. Next. Okay, but it's now is a guy first is going to the upper side. So I move to the parallel wire technique. Next, please. Second wire is a guy second. Next, please. So next. So the direction of the second wire is right side is Gaia second is not bad. Next piece. Next piece. Okay, now is the inner L view is second wire. The Gaia second is in a lumen, but so come on, next piece. Is a little bit outside of the two lumen. So we should consider about the retrograde approach in this kind of the situation. So, but we have a chance to penetrate again. So I use the seesaw wire technique using by the Gaia first. This is the first wire. So now I try to select the right side of the lumen of the inner outer view. So this is the current situation, right? So you can see the Gaia first is the right side. Okay, let's check the LL view. So if this penetration has been failed, we should move to the retrograde approach.
Okay, now you use the Gaia first and
Yes, Gaia first and Gaia second, but I control the Gaia first.
Gaia first.
Okay, now so wire is overlapped in LL view, so I think the RL view is more important.
Even this is a very short segment. It's best ways to prevent distal dissection, more extensive dissection.
Yeah. Yeah, but for me, I will step to retrograde because you see that if you extend your dissection somewhat beyond the trifurcation, then you might compromise, the three major branch. That is not the goal we like. So if the short trial like this, you already know that we have get us not successful. So we should considering retrograde is better way because I don't want a subintimal space expanded to the beyond the trifurcation.
Dr. Nasu?
Yes?
This is Dr. Ra. When I look at the angiogram, I feel this looks like a spontaneous coronary dissection from middle to distal with the combined multi-channel. How do you feel during the wiring?
So so one was a possibility, but I'm not sure. これ無理かな。硬いんだよな。まだ行くしかねえな。硬いな。
And especially when you push the Gaia first, where you can see the bending in the second, the segment 2. So indicate you might be facing a very hard break. So it's not a good sign to go. So maybe considering should be the time of retrograde.
You penetrate?
No.
Dr. Asakura, how do you thinking about this situation? You quickly move to the retrograde approach, or still doing the power?
I would like spend a little more time for the powered wire technique. But exit to CTO is bifurcation or trifurcation. It's a big program.
Yes.
So I never spent a long time.
Yes, of course. Okay. Okay. Let's check. Okay. If in the sub transfers, we should move to the retrograde approach. So retro, please. Okay. Okay. chance はね。Let's see. はいはい。寄ったはずだから。Okay, are you ready? Okay. Then
for the parallel wire technique, is it useful to have the same type of wire for the parallel, or you can have two different wires?
言ってねえな、ギリギリ言ってんだけどな、これなんとかなんねえかな。でもな、もうこれ以上やるの。
Very near.
Yes.
Still feel resistance.
Huh? Distance?
Still feel resistance. Looks like
some resistance.
So I think Dr. Nasu aiming to just the point of the exit point. So, but the wire is bended with the Gaia first. I think the black is harder than Gaia first. So you can keep the Gaia first there and then bring the Gaia second to the same point again.
Yeah, now I'm controlling the Gaia second.
You control Gaia second now?
Yes, but so maybe there is a sub-intimal space, maybe. Okay, let's check. Okay.
I feel this needs accurate puncture at that point.
It's inside?
Yeah, this view is overlapping. Wire and the contrast is overlapping this view.
Okay, let's go. It's no.
Oh, now in there.
Okay, let's check again. It's a very short time image. Very short time. Yes, we cannot take a long time picture. Okay. Let's go. You should.
Okay. Congratulations.
Okay, thank you very much. 2.5 on, please. 2.5.
So entered wire is Gaia first or second?
Gaia second.
Dr. Nasu?
Yes.
Which your lumen catheter are using in this technique? Sasuke or Crusade?
Unfortunately, today I don't have a Sasuke, so I'm using the Crusade. But fortunately, Crusade can pass the proximal tricky morphology side.
Thank you.
Could you check the ACT, please? ACT check. Can I see the wire? Wire is very important.
So, Dr. Nasu,
Yes.
I will move the next room and then go.
Yeah.
Then come back later. Okay.
Okay.
Dr. Dimitri.
Yes.
Yes.
So we.
Dr. Dimitri, you are on air.
Yes, thank you. So we did put the stent in the mid LED. We put a 3.0, and we're going to do a crossover in the left main. Little test, please. Yeah, I mean the ostium is okay, so it doesn't. We don't really need to nail it. Let's see the length here. I'm just going to do a dry scene. So that's a 38. So 28.
28.
35, 40, 40. Can we put a 40 in the proxy LED? Probably, right, Gary? 40, 28, please.
Do you have a time to review for me?
Yes, of course. Gary, you want to review the IVUS?
Sure. So after crossing and pre-dilating, we did IVUS. So this is the distal LAD. Here, you can see that it's small, disease-free. This, by the way, is a muscle bridge. So the distal end of the CT, or the LAD, is actually in the subepicardial space. So this is the muscle surrounding the artery. Then we get more proximal, and the muscle bridge disappears. Then we're into plaque. So the segment in the muscle bridge is disease-free. Disease-free, then you get a lot of atherosclerosis. Then we get to the area here, which is that trifurcation at the side of the distal cap. And this is the septal and this is the diagonal. And then we get more proximal, and it's just diffusely diseased. And you can see that the IVUS catheter is in the true lumen or intraplaque. Here's a large dissection as we're getting toward the ostium of the LAD. This is right at the ostium of the LAD. Circumflex is at 12 o'clock. You can see, calcific plaque opposite the circumflex, and then we transition into the distal left main. That is, has plaque but a big lumen. So it's a very, very diffusely diseased, reasonably calcified segment. Not very pretty. And then beyond it, you're in a muscle bridge.
I hope we stayed proximal to the muscle bridge.
Yeah, I think you probably can.
No, I put the first stent already, so...
We'll find out.
We will find out if there's an explosion. Huh? Yeah, that's okay. I'm okay with it. Yeah.
So you will plan to the full metal stent?
I'm going to do a crossover. The left main has plaque, so I'm going to try to take it almost to the ostium.
Plus the true ostium of the LAD is right here.
Yep.
So, it's not exactly a good landing zone.
Yeah, I think trying to nail left LAD ostia is...
You don't do it. You think, if you really check, nail it. You miss it most of the time.
Little test, please. Let me go a little. Little test, please. Little test again. I'm sorry. I need a little more. I can't see. I'm sorry. I'm getting old. More contrast. Okay. Why don't we take it here? Go ahead. Yep. Okay, and down. pull back a little bit and go a little higher. Okay, go like 14, please. 16. Down. And go like 18 there or something like that. 18? 18, 20.
18, 20?
Yeah. Down. Alrighty. Let's see what the damage is here. Just see the distal wire. Hold on a sec, please. Okay, can I have some nitro, please? Okay, ready?
Yeah, I'm ready.
Okay, so that diag, the bifurcation is coming back. I don't think I'm gonna chase it. I think what we're gonna do is we're gonna IVUS and see if we need to optimize at any point, Gary, and then we'll take it from there. Any other thoughts or ideas?
Why don't you show the spider or apicaudal to see the circumflex ostial area?
I will, of course I will. I just want to IVUS so that I get a sense if I need to do anything more, and then I'll give you the spider immediately after that. The ostium of the left circumflex, if I remember correctly, was not that diseased. And as you see, we have 3 wires. We have a wire down the circumflex and the wire down the first diag, which was before, just at the proximal cap. Nitro is in, right?
Yeah.
Okay, so this is our distal vessel. Yes, record please.
So again, this is the distal vessel. That's normal. That's the muscle bridge.
Just before the
Just
muscle bridge.
before. You got lucky. And, you know, the transition at the distal edge is fine. So far, no real areas of underexpansion. Maybe there.
It's a little eccentric, but it
There,
doesn't really
yeah.
matter.
And that's right at the major
First
diagonal. There's a lot of calcium there as well.
That should be left main pretty soon. This is the circ wire, right,
Right,
Gary?
right. There's a circ wire now.
Just going to disengage a little bit the catheter and see how poorly I did with the ostium of this left main.
Pretty good.
Not bad for a rookie, huh?
Yep.
Alrighty, so do I need to post-dilate?
Right at the diagonal that you have the wire in.
3.5 high pressure or 4.0 high pressure?
3.5.
Give us a 3.5 by 20 and see balloon, please. And should I make the left main bigger?
No.
Gary?
Well, let me give me 1 second. So this is the side of the diagonal that's underexpanded. And then here is the smallest part of the left main.
3.5 NC balloon?
3.5 NC balloon. We're going to go like 26 or something like that.
I mean, the left main is elliptical, but the area is fine. The area
I
is
think
huge.
it's small, Gary.
What, the left main?
Yeah.
The left main's okay.
Oh, you think so?
Yeah. The left main stent area is fine.
And how about distal MSA in the LED? Do we need to do anything more further down?
Well, all the way down, no. Because, if anything, there's a step up from the distal vessel.
How about in the area where there seems to be a little plaque behind it? Is there room to make it a little bit bigger there? Do we need to?
Where, are you talking about at the diagonal or elsewhere?
Yes, somewhere there.
Well, so this is the minimal, this is the area
Yes,
that's
a little bit more
underexpanded.
distally.
Now, this is right at the diagonal, Dimitri.
Okay.
And this is the one area that probably could be made a little bit bigger.
All righty.
It's, it's 5.5.
Okay, we'll do.
But I would
Gary,
have
one
said
of the question regarding the crossover from left main to RAT, but you can
just
see
go up there.
flow to the circumflex no diminish. However, we can see that downstream circumflex have some borderline lesion. So in the future, maybe we need, if the patient have progression. So what do you think about we need a dilatation through the centra to open the circumflex osteo. Although the FFR should be negative, but in considering the future procedure in the circumflex, I don't know, is it a good option to open the strut to the circumflex?
Good.
Okay, down.
We'll give you a spider now. And then we'll IVUS one more time. The question was about the stent struts.
Open the stent strut to the circumflex because downstream there's some borderline lesion. In the future, maybe we need to fix that circumflex if any progression.
I don't know. I've heard so many different opinions about whether this is of any use or not that I'm totally confused. I'll tell you a story in a sec after we take this picture. Go ahead. Ready?
Okay, I'm ready.
I think it looks pretty good. So I was doing a case for the Left Main Summit 5 years ago, and there was a similar situation like this, gentlemen, and they were telling me what to do. So I said I don't want to do anything. Then somebody was insisting that I should open it up. Then there was a third gentleman from the panel said, why don't you do an FFR? And if it's then positive, you open it up. So I said, okay, I'll do the FFR. It was 0.87, and they still made me dilate the stent strut. So we're not going to dilate the stent strut. Final IVUS, Gary? Wires are coming out from all the branches. Nope, that's the wrong one. That's the only one I shouldn't pull. Okay.
Okay.
You have the word?
Doctor, even in the left main, so in Korea, very few people doing the
I'm out of the stand, right, Gary?
Yep.
Yeah, I can
Okay,
say
pull back.
in Korea we are now doing the multi-center randomized trial. One is the true bifurcation, the other is non-true bifurcation. This kind of series made now 110 is a non-true bifurcation. We are randomized into the mandatory final kissing balloon and just leave it. And we are accumulating data. And true bifurcation, provisional
Not
concept
much better,
to stenting.
Dimitri.
How much better?
Single
Not much
stent
better.
with
Okay,
provisional
give me a
decision.
4 ONC balloon,
So
please.
if we look at that result, then we'll be fine. But personally, I feel that if there's some chance of disease progression in the circumflex, 65% or some future revascular chance, or the already stented area, the future TLR chance. In that case, I'm routinely doing the stool open. Otherwise, then later on, we can make the single vessel disease to the two vessel disease. We are injuring stabilize the left main endothelialization. So, however, the future TLR rate can be low, and
It's
just
a bit
is better to leave
It's
it.
not bad.
I'll do a
Stenting
4.
without kissing balloon. That's my strategy.
In this case, I think that the angle is such that the stent struts are so wide open that there's not going to be a problem for future access. I mean, if you really, it's your center. If you really want me to do a kiss, I'll do a kiss. It's going to take 2.5 seconds. But I don't think it's needed. Okay, let's go up there.
Right now?
Yeah. Let's go 18.
12,
18, 20.
18, 20.
Down. 20.
Actually, this
20.
kind of left main
22.
22.
in clinical practice,
Down.
we are not doing the kissing balloon. Just leave it.
Even in some disease, the circumflex?
Yeah, right. We have done a series of several
22.
hospitals. We have done the jailed
22,
circumflex
yep.
left main study and published in the Korean
We're not going to
Circulation
re-IVUS,
Journal.
Gary,
Even
since it
looks
was 6.4
80%.
already. I went 20 atmospheres with a 4.0.
FFR negative. So just the team is free flow and the 90%
We'll
and not
test, make
so
sure that
dominant
everything is okay
circumflex.
distally.
I think it's better to leave it, not to injure the area.
Okay, final picture.
Okay, this is the final?
We think so, unless we see something that we don't like. Yep.
Did you give nitroglycerin?
Yeah.
For the distal?
We can give some more nitroglycerin. Remember, part of it is intramyocardial, as we saw by IVUS, but I'm pleased that we have, the diags in place. The circ looks good, so given the relatively limited options, I think that's probably not a bad result. You're going to give some more nitro?
Yeah.
And we need to wait. Let the flow do its thing, remodel the vessel. We have good outflow, the septals are there, so I'm not concerned about, any issues acutely. I think there's enough outflow to support the stent. Am I in still? Oh, no.
Okay, Dr. Dimitri?
Yes, sir.
I have to move. Thank you very much. Congratulations on your nice case.
Thank you.
Thank you.
It's been a great pleasure and an honor to operate in such a prestigious center. Thanks for having
Okay, Dr. Nasu?
Yes.
Another 10 minutes.
Yeah, after crossing the wire, I tried to dilate it by the 1.2 balloon, but actually 1.2 balloon cannot pass the most distal severe side. So I used the anchor balloon technique in RB branch. So I dilated the RB branch by the 2.0 balloon. Finally, the 1.2 balloon can pass.
Okay, good.
Okay, now I would like to concentrate to select the PD branch. PD branch is also very big, right?
What's the name of 1.2 balloon?
Ikazuchi maybe, yes.
Ikazuchi.
Okay, could you?
Connect 1.2 by 6 millimeter. And these days we have a very good 1.0, including your LUX 1.0 by 5 millimeter, or some other even Korean company, several 1.0 balloon.
I see. I heard about the 0.75 balloon.
0.75
balloon.
Anyway,
Anywhere in the world.
Yeah, slender. Not only the slenderness, the shaft support must be important to push.
Shit.
So you introduced the crusade?
Yes, of course.
Can pass?
No.
Yeah, I think so. That just only do the 1.2 balloon
Yes,
only.
I need to the 2 balloon.
Yeah.
Okay, 2 balloon, please. But I would like to damage for the bifurcation. So I try to once, if possible, impossible, I dilated by the 2 balloon. The XTR, please. XTR. So Sasuke will pass. But unfortunately, I don't have Sasuke today.
Please explain Sasuke because this is in Korea.
Yes, Sasuke is a double room in Kasita. Is from the Asahi Intake. And maybe someone will explain it tomorrow, the CCT session. Sasuke is a very nice crossability compared with the Crusade. And also the duration of the kinking is a very hard shaft. So never kink. So, and also the crossability almost similar, the same as a Calabero or something. So after crossing the 1.2 balloon in this kind of situation, so Crusade cannot pass like this. But maybe if I have the Sasuke can pass this CTO region very quickly.
I explained the name of Sasuke. Sasuke is a ninja.
Ninja, yes.
Ninja, do you know ninja? Ninja.
Ninja turtle.
So what is the profile? This one
profile.
Yeah, 2.
Profile, almost 3 French.
3 French.
ちょっとわかんないな。これあんまりアンテから落ちたくねえんだよな。これかな。わかんねえな。レトロから打っても見えないしな。ヤン。どうだったっけ。結構角度が。
Dr. Asakura, did you already use the Sasuke frequently?
Not yet.
No.
Can we have a retrograde contralateral injection?
Okay.
Yeah,
okay,
can we just help you to access the PDA?
Okay, let's go. Maybe we cannot. Oh, we can see, but there is some dissection with something there.
Dr. Nasu?
Yes.
It's too difficult to wiring integrated. How about the reverse wiring technique?
Wow.
However, the proximal is a too slender caliber to sending reverse wire. It will be better to dilate, like 2.0 balloon. The proximal.
Yes. Yeah, I tried. I dilated the two balloon.
Or before we dilate with 2.0, is it possible to see IVUS at this point? What do you think? The IVUS can pass?
Okay, I already have the IVUS, so I tried the IVUS before balloon dilatation. Okay, could you keep this one? Yeah, this is XTR. Okay. Shit. I cannot go. So this is the inside of the tricky channel here. So could you pull back? Minto sensei いないのか。あ、Mitsu sensei いないのか。
Because Crusade cannot pass, IVUS cannot pass.
Yes, yes, usually.
It's better to do the 2-0 balance.
あれ、プルバックしてないよ。Could you record and pull back? Pull back. Oh, okay, pull back. Okay. So maybe inside this channel, the vessel size is almost 3.0. So here is the most proximal side inside the channel. So we can see some frog. Maybe this is the RV branch. It's come from the another channel. It's a double lumen point. So maybe we can see some dissected, some kind of a lotus root findings. So maybe in the OCT findings in this kind of a region, we can see the lotus root.
Yeah, this looks like the scarred.
Yeah. Yeah, this is the proximal side of the stenosis side. The vessel side almost 3.5. And now we can arrive to the proximal very big vessel. So this is the branch. You can see the wire. The proximal side is fine. So I would like to delete the 2.0 now and check the IVUS and try to select the PD branch and put the stent.
Stent from the where?
So after crossing the PD branch, I would like to decide, but maybe the AB is better, I guess. But it's very difficult to decide now.
Okay. So now we are time to limitation.
Okay, thank you very much.
Thank you very much, and a nice case, and congratulations of the successful wiring.
Thank you very much.
Thank you very much. Okay, so now we all finished the live transmission. Maybe all of the cases successfully across, and thank you for cooperation. Thank you.